evening to our speakers, chairs, and audiences of the ACNS webinars in different parts of the world. Welcome to yet another edition of Educational Webinars Just For You. Today, we are going to hear two very special lectures in the coming few hours. The speaker for the first session of today is our honorable guest, who is a pioneer of gamma knife radiosurgery from Japan, Professor Motohiro Hayashi. Professor Hayashi is the director of the gamma knife unit at the Tokyo Women's Medical University and also serves as the associate professor in the Department of Neurosurgery at the Tokyo Women's Medical University. He is also the director of radiosurgery section of the Medical Innovation Laboratory, Tokyo Women's Medical University and Waseda University. Professor Hayashi was a past vice president of the radiosurgery committee of the WFNS and has also served as a member of the board on the radiosurgery committee of the WFNS. He is the founder of the Asian Gamma Knife Academy training program, and we are extremely honored to have him today to be a speaker at our webinars. And today he'll be talking about gamma knife radiosurgery basics and application in neurosurgery. The speaker for the second session of today will be our honorable guest from Chile, Professor Sergio Aguilera Rodriguez. Professor Aguilera is a neurosurgeon at the Herminda Martin Hospital, Chile. For more than 15 years, he has developed different academic activities related to neurotrauma, neuromonitoring, neurocritical care, participating in different congresses, consensual conferences, clinical guidelines, and writing scientific articles. In addition, for more than 4 years, he has held management positions in Latin American Neurointensivist Society, LABIC, and recently he has participated in the Seattle International Consensus Conferences. We are extremely honored to have him today as a speaker at our webinars, and today he'll be talking about moderate traumatic brain injury clinical approach to an inappropriate term. The chair for the first session of today is our honored guest from Saudi Arabia, Professor Imad Kannan. Professor Kannan is a senior consultant neurosurgeon at the King Faisal Specialist Hospital and Research Center, Saudi Arabia. He is a vastly experienced neurosurgeon with several publications in various peer-reviewed journals. He is the chairman of the Neuroanatomy Committee of the WFNS and has contributed greatly towards the neurosurgical education for the young neurosurgeons by conducting several online webinars. We are extremely honored to have him today with us to chair the session of Professor Motohiro Hayashi, and we also extend our heartfelt gratitude to him for his everlasting support for us all through right from our inception of this webinars. The chair for the second session of today's webinar is Professor Virendra Dev Sinha. Professor Sinha is a consultant neurosurgeon at the Savai Man Singh Medical College, Jaipur, India. He was a past president of the Skull-Based Society Surgery of India, as well as the president of the Neurotrauma Society of India. He currently serves as the chairman of the Neurorehabilitation and Reconstructive Neurosurgery Committee of the WFNS. He has also been instrumental in conducting online webinars for the benefit of the neurosurgeons of the world on behalf of the WFNS. We are extremely honored to have him today to chair the session of Professor Sergio Aguilera. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Imad Kannan.
Welcome to all of you, and it's a pleasure to meet you on the webinar this time, and I hope I'll meet you in person in the near future. It's first, I'd like to thank Professor Yoko Kato, the driving force of the Asian Congress on Neurological Surgeons in education and teaching young generation and women in neurosurgery, and Professor Raja, Professor Ibond for inviting me to this webinar to chair that first part of this webinar. And it's a privilege to meet Professor Motohiro Hayashi in person. I followed his wealth of publication over the years. He covered gamma knife experience in different aspects, from neoplasm oncology to functional and to vascular. And he is kindly is going to share his vast experience in that field, which I'd like to heard about it. My first exposure to gamma knife was Professor Steiner in Charlottesville, Virginia, where I visited him several times. Then we acquired the Cyper knife. This is where I built up some experience, but I'm still a skull-based surgeon and vascular surgeon. And we found the colleague covering gamma knife. They are our partner on the mission to treat our patient at best, not rivals. The same with interventional radiologists. Without further ado, Professor Motohiro is the podium for you to present your presentation. Thank you.
Good afternoon, everybody. So I'm Motohiro Hayashi from Tokyo Medical University. Thank you very much. My announcement from Professor Kannan. So today I'd like to talk about gamma knife micro radiosurgery based on the advance. So why I'd like to the name micro radiosurgery. So usually micro gamma knife surgery is dedicated to the MRI CT scan, and we can think about pathology or something. But so in this presentation and our basics, it's our radiosurgery planning based on microanatomy. So we neurosurgeon, it's very important to know microanatomy, not only neurosurgery, but also radiosurgery. So first of all, I'd like to show the base structure of gamma radiosurgery. So maybe now you know very well. So gamma radiosurgery system is very simple. So 192, the modern system 192, cobalt 60 is an arranged like this. So each cobalt 60 delivers gamma ray like this, and only one point accumulate and deliver high dose, high power to the target. So nowadays, we have more than 300 gamma knife units in the world. So I indicate each centers as a square. So a lot of American, Europe, and our country, Japanese, and we have now 53 sites in Japan. So a lot of gamma knife sites. The history of gamma knife in Japan. So this photo is in the Professor Lexus. So he invented gamma radiosurgery. The first of all, the system was X-ray radiosurgery systems. So in 1951. So after 17 years, Professor Lexus invented using cobalt 60s. So after 1990, we have first gamma knife radiosurgery system in Japan, and in our hospital, Tokyo Medical University, 1993, as a 10th term. So after that gamma radiosurgery, the system changes, manual chain mode to APS, Model C, and now we can have the perfection. So this is the newest machine of gamma radiosurgery. So this photo was on the original prototype of Lexus gamma systems, so like this. And after that, Model C is like mechanical things. And now we have the perfection systems. So this is very accurate machine. The treatment accuracy achieved in 0.05 millimeter, 50 micron levels. And if the patient has more than 10 regions in the skull, we can treat in the one time. The full auto-imposition systems provide speedy treatments. Now we have no human error. So nowadays, and we can have the icon systems. So this is the newest machine, and much more than perfection systems. So this is a CT guided images and installed. And this machine, we can do not only stereotactic radiosurgery, but also stereotactic radiation therapy, fractionated radiation therapy, and now we can do that using gamma knife systems. So they schedule gamma knife in a hospital. The first, a frame application. So we can use a Lexus frame to put on the patient head to not moving, stabilize very well. The second one, so we can do the diagnostic images, CT scan, MRI, angiography. And third one is dose planning. So 99% of the doctors working in a gamma unit is a neurosurgeon. So we can have about 500 to 600 images of MRI, CT scan, angiography. We can make a dose planning based on microscopic surgery. That time, so we have to note microanatomy from the MRI and CT scan and the angiography. So finally, we can finalize dose planning on the computers. After, so this computer data we send to the treatment machine. So these 4 steps is needed for the patients. So such as 8 o'clock a.m. we can start, and 11 o'clock a.m. We finished one patient. So nowadays we can treat a patient 2 or 3 or 4 patients per day. Majority of the patient is a day surgery, no hospitalization. So 28 years experience in Tokyo Umeå Medical University, Professor Takakura installed this machine in 1993. So now, 28 years past, we have over 8,000 cases. The majority is the brain metastasis, about 50%, ABM 10%, acoustic tumor, meningeal pituitary-adenomas, skull-based tumors is about 25% all, and 4% trigeminal neuralgia and other functional disorders. So such as brain metastasis cases, example, 81 years old male patients, no actor. So the patient has a brain metastasis from colon cancer. So after operation, first of all, the tumor was too huge to do gamma radiation surgery. So after resection, we can have the residual tumor. So this is not so small size because this tumor inside there is a middle cerebral arteries. The patient wants to be back to his job, so we cannot make a damage to the patient, paralysis. So we have the residual tumor intentionally, and after we did do radio surgery, 3 months later, the tumor was gone without any complication. However, some cases, so after radio surgery, the patient has still have the enhanced region and associated with big edema. So this is due to radiation necrosis. So if we missed those burning, higher doses, much more higher doses, or much more covering, the patient has a disaster. So some patients, so before radio surgery, the tumor was very small from renal cancer, but we did radio surgery 7 hours in the unit. Finally, the patient blood pressure was higher. Finally, the patient consciousness was down. And after that, we did do CT scan. CT scan demonstrated a huge hematoma. So this is one iatrogenic radio surgery things. We have to pay attention to the patient's condition. So gamma radio surgery is not radiation therapy. This is image-guided surgery. So this is a concept from France. So about 20 years ago, I went to the Marseille, France. So this photo is a Professor John Regis. So he's very famous in the world concerning radio surgery for epilepsy, endothelial pain, and wound disorders. So why I wanted to go to Marseille, France? So my aim is to run the functional disorder radio surgery. So during 2.5 years, so I started stereotactic neurosurgery and the pain radio surgery and epilepsy radio surgery. So this is my diploma. So I was certificate of the French neurosurgery. So I could speak French a little bit now. And during the stay in Marseille, France, I have very good sentences. So gamma knife originated from stereotactic neurosurgery, not from radiation therapy. So I demonstrated 2 sentences. One is making target with Lexington frame and making effect to a target using needle insertion. So this is the stereotactic functional neurosurgery. And the second sentence is the same one, and the different is the last 2 words, irradiation beams. This is gamma radio surgery. So before coming to the Marseille, France, in my opinion, so gamma radio surgery is one of radiation therapy. I did a treatment for the metastasis, skull-based tumors, but my concept is radiation therapy. But after coming to the Marseille, France, So I experienced treatment with functional disorders. So they said treatment accuracy needs 0.1 millimeter levels. So we have to put the frame to the patient, and then no tilt, no rotation, no doubt. Very strict treatment is needed for cell-duct reduced surgery. And before starting reduced surgery, we have to do frame application. So this is very, very important. When we treat the patients, paracellular tumors, cavernous tumors, frontal-based tumors, amalgama, so we have to do oblique frame application because of this line should be parallel to optic nerve or optic tract. So optic nerve, optic tract is very important structures because these structures is very weak from radiation. So we have to protect very carefully. And second on MTLE, major temporal epilepsy, or paracellular posterior expansion. So we have to frame a little bit oblique. So because we need this frame should be parallel temporal lobe axis. After that, we can have a very good MRI images, corner view, which demonstrate each important structures. And on the other hand, when we have to the treatment with a patient with a neuralgia, so we should frame application should be parallel to the trigeminal nerve, a little bit up. So comparing the two, so this frame application is a little bit on the anterior up. And so the very important thing is in the imaging. So MRI is very important. So when I back to Tokyo, my first task is to invent the new MRI images and dedicated to gamma ray surgery. So T2 images or modified TO images. And nowadays, we wanted to have the CIS images, you can know. Fiesta or CIS 3D heavily T2 image is very important. So this is visualization in the posterior fossa and it's very good. We can know the tumor. And so our new idea, so we intentionally use the gadolinium of the CIS images. After that, the tumor became transparent. You can compare the left one and right one. The tumor became transparent. Finally, we can know the surrounding very structures, surrounding very important structures, such as green one is facial nerve. So this was planning, covering the tumor as much as possible and completely separated from facial nerve. So this dose planning is very important for the acoustic tumor manipulative surgery. So from now, I'd like to demonstrate the skull-based tumors. First one, acoustic tumors. Already published in the Journal of Neurosurgery. So we can say gamma radial surgery is the image-guided robotic micro-radial surgery. It means precise radial surgery with automated position systems using higher quality of the dedicated MR images. Cell-type radial surgery, gamma RNA surgery as a concept of microsurgical procedure. So our aim is not only control the tumor, but also rapidly and remarkable shrinkage, and not only prevent worsening malfunction, but also recovery to improve function. So this is schema of acoustic tumors. So this is tumor, this is facial nerve, this is acoustic nerve, and this is cochlear nerve, vestibular nerve, cochlear semicircular canal, this is pons. So we'd like to put 4 mm isocenter. It's running 7th nerve, not beyond 7th nerve, and the covering of the tumors. So we have to pay attention here because the tumor, the surface is capsule. The very near there is an arachnoid membrane. If we isocenter it's the over the capsule, so in the future, this tumor has a very, very strong adhesion between the arachidonal membrane and the tumor capsule. If the patient needs operation, so if stupid dose planning, so this isostem is covering much more, so this will be the disaster. So we have to pay attention. Each isocenter is inside the tumors, and we have to pay attention. 7 snub running, so no irradiation. And after, so we have a higher hotspot in the posterior fossa. So this is 20 gray areas. So if we do like this, the tumor easily have necrosis in 2-3 years later to radiosurgery. So this is a Kussmaul stage tumors. This is coronal view, MRI view, CT bone images, axial view, and sagittal view. So this is stage 1 tumor. So you know this is a facial nerve. This is an acoustic nerve. The tumor is here. So this is a coronal view. So this is an acoustic nerve. This is a tumor. So the tumor tail is in the inferior vestibular group. It might be the tumor came from inferior vestibular Schwann cells. When we have to make a dose planning, we have to know bony structure, microanatomical point of view. So this is horizontal bar. You know very horizontal bar. This is between facial nerve, cochlear nerve. This is between superior vestibular nerve and the inferior vestibular nerve. This is a horizontal bar. So this is horizontal bar on the CT images. So this is Bill's bar. The Bill's bar is between seventh nerve and the superior vestibular nerve. And so we can know here is the facial notch. The facial nerve exit here. So this bony structure is very important. So this is stage 1 tumors, 3D images. So this patient is very lucky. The visualization of each nerve is perfectly. So this is facial nerve, acoustic nerve, superior vestibular nerve as red, inferior vestibular as orange, purple is a cochlear nerve. So only orange one is cut off. It means this tumor might came from orange one, inferior vestibular nerve. We can suspect. So current dose planning for small acoustic tumors. So not only CUS1, CUS2. So this is middle-sized tumors. So this is axial view, coronal view, sagittal view. This is cis gadolinium. This is cisplatin. So when we have the patient with CUS stage 2, coronal image is very important. This is the patients. The tumor is embedded in the inferior vestibular groove, like this. So it means the tumor came from inferior vestibular nerve. After that, the tumor is expanding and the facial nerve was pushed anterior superiorly. So this is a facial nerve. On the other hand, so coronal view demonstrated cisternal images, CSF color is in inferior vestibular fossa. So the tumor tail is the superior vestibular groove. So it might be superior vestibular nerve schwannoma. At the time, so the tumor compress, seventh nerve is only anteriorly. So seventh nerve is here. So the nerve, seventh nerve is in the coming in here and running here. And so this is facial nodes. The nerve was running out from here. So we can know where is the facial nerve very well. We have 0.2 millimeter space intentionally here. So this is a very rare case, 2-3% of the acoustic tumors. That is cochlear nerve schwannoma. The tumor extended in the cochlea is very easily, and very interesting structure is facial nerve is just superior to see. The cochlear nerve is here. So the seventh nerve was compression to the superior. So this is wrong pattern from the GKRS distribution normal. So this is a molecular change in MR after gamma radiation surgery. The after radiation surgery, the majority of patients experienced transient volume up release. So this low intensity area, we can say that we can call loss of central enhancement, LCE. LCE means the tumor might be schwannoma. After 1 year from the first radiation surgery, the tumor has a shrinking, no inflammation, and after the tumor is the gradual shrinking. Some cases, the very large tumors. If the patient is elderly, we cannot do surgical resection under general stage. At that time, we have to do radiation surgery for this kind of patients. So stage 3 tumors. So this is cystic tumor. So we'd like to use gadolinium. The tumor became transparent. We can know not only the tumor, but also sound structures. This is magnified. And we'd like to cover the tumor. So this actually from bottom to top. This is a tumor. And this is a 5th nerve. So this is a 7th nerve. And so we can pay attention not only 50% of those areas, but also inside 80% high dose areas. If we do intentionally making those burning, the tumor has a chance to have big energy from the radiation surgery. It means the tumor easily to shrinking because of tumor necrosis and due to radiation surgery. So 80% those should be occupied in tumor as much as possible. The time so we'd like to pay attention, each isocenter is where. So no isocenter outside the tumor as much as possible. Especially so brainstem side, we have no beyond covering isocenter. So if the patient needs operation because gamma radiation surgery is failure, about 3% of the patients, that time we need surgical operation for the patients. So if we have disaster treatment dot burning, the tumor has a strong adhesion due to inflammation, the operation itself would be the disaster. The patient easy to have a facial nerve palsy and geysers. So we like to pay attention, consider for the failure cases, if the patient is a failure. So gamma radiation surgery is very effective for any cases. And we have to know the 50% of those areas and comparing of the bone images. So this is very strict. We can know the 50% is where. So this is a facial notch. This is Bird's-bar. So usually the facial nerve is the entry is here. And the running here, finally is the exit. So 50% those areas not involving facial nerve completely. So this is stage 4 multicystic tumor patients. The patient is Hausen class 1, Gardner class 1. The patients does not want to be treated by surgical resection. So we did radiation surgery, 4 years passed. The tumor is much shrunk. So before radiation surgery, the patient was a professional golfer. After that, now he became to the doctor with small acquisitive tumors. Very successful case, not only for the tumor, but also for his life. And another one case for 84 years old patients, the patient is very elderly. And when the patient has further gamma radiation surgery, the patient has trigeminal neuralgia, secondary type. So we challenge radiation surgery for the patients, but 3 years later, the tumor is a little bit shrinking, but the patient has still has trigeminal neuralgia. So we have to do release trigeminal neuralgia from the patients. So we decided to do such resection. So this is operating the view. The tumor was no adhesion and very good visualization of the surrounding nerve, and taking the tumor without bleeding. And finally, the fifth nerve is detaching from the tumor. It's very easily. So usually, the common sense of the skull-based surgeons after little surgery, probably the operation itself will be the disaster because strong adhesion. But our experience cases, 6 cases after little surgery opposite tumors, all patients had no adhesion, no bleeding. The neurosurgeon comment, very easy to remove the tumor cell. So we go to the meningiomas. The already published skull-based tumors, our unique concept. So this is schema. So this is Peter's meningioma. The tumor came from the dura mater and arising. The tumor has a capsule. So we put isocenter is a basal attachment because basal attachment has a lot of rich vascularity and a very active tumor cell is here. So we'd like to put isocenters, the high energy to the basal attachment and surrounding the tumor surface and inside. So finally, so we'd like to use 20 gray high dose areas should be occupied in the tumors as possible. We'd like to give higher energy to tumors. Our aim is not only stabilize tumor, but also rapidly shrinking. So like this, like this, like this. And so radiation itself has two methodology to shrinking the tumors. One is cell apoptosis, you can know very well, and one is tumor necrosis. So even if conventional radiotherapy, so necrosis was the main essential systems. So gamma radiosurgery is a very higher energy to tumors. So necrosis is very easy to triggered by the treatment. So this is the case, skull-based tumors, Peter's apex meningioma. So this is cis images. So cis gadolinium, the nerve was here. So delineate delineate as a red line. And we can cover the tumor with 50% those areas, and the inside 80%, 20 gray areas inside should be occupied as much as possible, but his nerve is inside running. So we can avoid this nerve from 80% of the lines. So this patient is very lucky. After only 2 years, the tumor has much shrunk with any deficit. So this is one of evidence of our little surgery. It's very effective. So we can calculate unit energy. So this is the homogeneous index. So this index is higher, and the tumor shrinking rate is higher. So this is a significant relation. So cavernous tumors. So microanatomy is very important. So this is cis plane, this is cis gadolinium. And we can see oculomotor nerve is here, and in the cavernous sinus, we can see the oculomotor nerve. So cis plane, we cannot visualize very well. So this is very effective using cis gadolinium. And so this is sixth nerve is here. So this is the vaginal vena plexus. Usually we can visualize vaginal plexus, but if we use gadolinium, so this portion is transparent. So this is Dorello's canal. So this nerve is running between the ICA and the metal caves. So usual CIS plane, we cannot visualize 6 nerve. So this MRI is very, very important when we have to treat a patient with cavernous sinus tumors. And the gamma systems, we have the 3D demonstration systems. So oculomotor nerve, cavernous sinus itself, trigeminal nerve, abdominal nerve, and this ICA. So we can understand three-dimensionally each nerve and the cavernous sinus systems. The cavernous sinus is here, and there is a canal, and this sinus going down to the vaginal plexus, and going up laterally superior petrous sinus. So this sinus anatomy is very important. So we compare the textbook each time. We published 120 patients with cavernous sinus tumors. We have 3 patterns. Extension pattern, one way like a pituitadenoma, expansion pattern, many multiple ways like a chordoma, invasion pattern. So this is a crossing disease or invasive malignant or atypical meningioma rarity. We have some categories, so such as pituitadenoma. So this tumor came from pituitary gland. So this is schema, and the pituitary gland is here. And after the tumor expanding inferior to the vaginal plexus, laterally superior SPS, and posterior superiorly pulse oculomotorius. Case 1. So this is T1 gadolinium. So this is a tumor. The tumor is located posterior superior extension. So T1 images, we can visualize each cranial nerve. But if we use cis gadolinium, we can see third nerve and sixth nerve. So this tumor expands into the posterior superiorly. So we have to pay attention only third nerve relationship. So sixth nerve is not so important on this case. The case 2, the tumor is located in the inferior posterior cavernous sinus. So posterior inferior extension pattern. And same as using cis gadolinium, third nerve is intact, no care. But sixth nerve is, we can see that, but here we cannot see that. Probably the tumor came from here, the sixth nerve is compressing lateral inferiorly. We have to pay attention this side, those planning very carefully. We did not have any complication due to radiation, sixth nerve, third nerve diplopia. So next one, the ultraviolet malformation. So I'd like to demonstrate no easy cases today, inductive case, such as thalamus intercapsule huge AVM pediatric case. So this girl and onset 6 years old. After that, gradual paralysis. After the mother wants to pass through the MRI the patients. So finally, the MRI demonstrated AVM in the deeper parts, but very huge. Any doctors did say that we cannot treat. So finally, the mother took the patient to my consultation. The big, huge AVM. So this is actual view. So this is very big drainer, the very huge nidus involving internal capsule. So the girl has gradual progressive paralysis. So the mother was crying very well. So for the audience, do you want to treat the patients or no treatment, only observation? But the patient onset and the patient symptom is very severe, gradual paralysis. So we can look after why gamma radio surgery making AVM disappearance. So we have 4 steps. So for these patients, very important is third steps. First of all, radiosurgery to the endothelial cells 1 year after the capsule is in the thickening. So the bleeding rate is very, very less from the timing of radiosurgery. After that, 2 years, the endothelial cell is much more thickening. So much more not bleeding chance. And so on the other hand, the red cells very few because so the flow of the nidus cell is very, very down. So these patients gradual hematopoiesis due to a high flow or compressing intercapsule from the drainage. If we can reduction flow in the ABM, of course we cannot make a disturbance of ABM, but the patient onset is gradual processing pain paralysis. If reduction is completely, the patient onset is improving. This is my idea. So Vascular surgery is not for disappearance. This is for flow reduction to the drainer. So we covered the nidus just adjacent to the drainer. This is just entry region of the nidus cell, a part of the nidus. But so we'd like to think about this area is very important main shunting of ABM system itself. Only 4 cc. We need 22 gray as a marginal dose to the nidus occlusion. 22 gray volume less than 4 cc is a very safe. This is a complication of point of view. So after radiosurgery, sorry, this is the before radiosurgery. After 3 years, so the nidus was majority of nidus was disappeared. I was very surprised. Not only covering parts, but also outside ABM itself. So second time radiosurgery, the residual part is very, very less. So second time radiosurgery aim to the same of the usual ABM disappearance. So we need to use angiography, profile view, until Pathophysiology view, MRI, and the CT 3D images. So this is the second time radiosurgery. So the drainage cell was shrunk and comparing of the first radiosurgery. So this is second radiosurgery. And 10 years later to first radiosurgery. So the nidus itself was very, very small. So we cannot see the nidus cell. That is very difficult. So this is an gamma radiosurgery the first time. So this is a latest MRI. The small tissue nidus here. So we did do last gamma radiosurgery 2 years before. Maybe now the patient has no ABM nidus completely without any complication. The patient gradual processing hematopoiesis was stopped. So this is a very lucky case. So after that, so our aim is the same principle. Our target is just adjacent of the drainer, the nidus cell. So this case is an incidental onset, 10 years old boy. So we did radiosurgery. Only 8 months later, very small residue. So 18 years later to first radiosurgery. So nowadays, completely disappearance. So we are also surprising, but our majority case is like this. So this is a 3 centimeter basal localized in midbrain. So this is a very difficult case to do such a resection. We did radiosurgery only 1 year. So the lady is now 28, 25 years old. So they just married after completely disappears ABM. And now the lady has a pretty baby. So if the lady has still ABM, the patient has no baby. So this is very important treatment for young lady, I think so. So high-grade pediatric ABM, we experienced 15 cases in 20 years. So complete disappearance, 46%, and clinical disappearance, 77%, significant effect. That means completely disappearance, clinical disappearance, and slight residual. It means another gamma radiosurgery after will be completely disappearance is about 85% patients. ADL persisting rate 86%. So now we have the very good result of the very difficult cases. So now I'd like to demonstrate short films on the TV.
Medical Frontiers. Hayashi has been working on an exceptionally challenging case. He believes it's the first of its kind to be treated with a gamma knife. The patient is 11-year-old Noa Takahashi. What makes her situation so unusual is that she was born with multiple arteriovenous malformations all over her brain. Last year, one of them ruptured. Before then, she was able to carry on normal conversations with her family, but the rupture put her in a coma.
There are no reports of curing severe consciousness disorders with a gamma knife. But I have treated 700 cases of cerebral arteriovenous malformations, and the technology has always been effective. I think it's a matter of getting the dose right, or applying the gamma rays effectively. When the beams accurately hit the target, children improve dramatically.
First, Hayashi operated to stop the bleeding in Noa's brain. Then, he used the gamma knife to save her remaining brain functions. Six months have passed since she had the treatment.
Noa-chan. Noa-chan.
She responds more often to stimuli like touch or when people call her name. With support, she can now assume a sitting posture.
I see hope. I feel more resolved than ever not to give up. In the past, I thought she might die in a week's time, but now I'm not going to give up. Never. I want to hold her hand and walk together. I promised her.
It is possible that the parts of her brain that control language are intact. So if everything goes well, I think she'll be able to speak someday. We'll continue with the therapy without giving up. And when she grows up, I hope she'll open her eyes to say, "Thank you, doctor," and "Thank you, Mom." To make that happen, we'll do everything we can.
Medical Frontiers.
So the 4 years passed, the first radiosurgery as now. So 10 months, 1.5 years, 2 years, now 4 years passed. So she was going to the school now. the patient has a little bit speaking now. So we cannot give up for huge ABMs. If we have a chance to treat, we have to challenge for the huge ABM. This is my evidence. So we have very few times under my presentation, the functional disorders, I did quickly presentation. To the neurology, this is one of the options of laser surgery indication. Now we have a lot of the patients. The success rate is about 90% of the patients discharge free. And interpain, so we already published in the journal Neurosurgery. So such as the patient has a cancer pain, our target is the pituitary gland itself. 180 gray to the pituitary gland. The patient has very less complication, but significantly pain reduction we can experience. Not only cancer pain, but also Salmonella pain syndrome, post-stroke pain. So this methodology was also effective. About 70% of the patients experience pain reduction significantly. So our target is pituitary gland itself, and 180 gray at a very huge dose, and only one isocyanide using 8 micrometer. So covering the pituitary gland itself, and the 10 gray area should be separated from the optic apparatus. Epilepsy, so I experienced in the Marseille, France with Professor Regis. They have a lot of patients. With this publication demonstrated about 60% of patients successful after little surgery in very, very intractable medial temporal epilepsy. This is dot burning. And so to neurology and the other pains and the epilepsy itself, we don't know why the gamma laser surgery has effective for these cases. So we did do experimental study using rats to prove action mechanical function disorder in gamma surgery in Japan. So we exported from France. So this is a rat dedicated frame of the gamma knife itself. We can put the rat here. And we have two types of the publication. So we have the accuracy in the frame itself. So this system, so we need to put the rats on the frame, the human MRI, and after our target is a striatum, about 4 mm diameters. Our target is a 0.1 mm levels and shots of radiation. So our target is here, and this is specimen. So this is we can have evidence of accuracy of the total. So last our experimental studies, and we can have the sciatic nerve neuralgia. So this is like a trigeminal neuralgia models. So finally, so our paper demonstrates that. So laser surgery might introduce degenerative effect to the injured cranial nerve. So now we have not only laser surgery, so that exception from the United States. So now we'd like to have 2 centers in the nearest future in Japan. So this system is very simple and no frame application and very accurate. We expect so these systems is going well in the future. So there it is. So this is the following RAS strategies. So now I did do Asian contribution. So I invented the Asian government program. First and second one in Japan, third one in Korea, fourth one is Taipei, fifth one is the St. Petersburg, Russia, sixth is Shanghai, China, seventh one is in Hawaii. So we'd like to share the experience, and we'd like to treat the patient together. And so young neurosurgeon or potential gamma radiation surgeon wants to participate in this Congress. So this is a very friendship team. So third one, fourth one, fifth one. And after, so we have the publication internal textbook from Springer and Shanghai, Hawaii. And this year, the end of July, we have a second edition of the internal textbook. We can access to Springer. If you're interested in this internal textbook, please get it and study it from the books. So I did do a long time the presentation. So thank you very much, merci for the attention. So the next Olympic game is held in Paris. The concept is a bonnet pathology. That means common and share together. So if you want to learn more about gamma radiation surgery, not only tumors, vascular, but also functional disorders, common and share in the Tokyo Wayne Medical University. Thank you for your attention.
Thank you very much, Professor Kannan.
Thank you very much, Professor Motohiro Hiyachi, for this wonderful presentation. Very impressive. Congratulations on these materials you have collected over the years and the trend to be more advanced, and your involvement in education, not only your peers, but your international colleague and young colleague neurosurgeons. I will give a few comments, perhaps questions. I cannot bring too much questions because everything you put was based on science and very meticulous studies, and congratulations again for that one. I have one question. I remember this question of put on Professor Steiner on cavernoma and brainstem. You touched the major issue, the AVM, but cavernoma is a low flow malformation. And he used to say low flow malformation does not respond very well as the high flow AVMs for gamma knife. And what is your perspective after these years of experience on this issue? Because many neurosurgeons, they start tackling the brainstem cavernoma, they want to eradicate the disease, but some on the cause of neurological problem.
Okay. Totally, so I have experienced over 10,000 cases of the patients. But among of the 10,000 cases, only 20 or 25 cavernoma in the brainstem. So not a huge experience, but gamma radiation surgery was very, very effective for the patients. After radiation surgery, very few cases of the rebleeding. And after 2 years from the gamma radiation surgery, close to zero, almost 0% of rebleeding. So our treatment indication is very strict. Repeated bleeding, only one time hemorrhage, this is exclude indication. More than 2 times bleeding cavernous angioma is easier bleeding of the cavernous angioma types. So this is first category. Second category is a very difficult approach. So like a brainstem. So, and we cannot approach to the surgical things. So this is second category. Third category is the potential to damage another neural deficit when the next time rebleeding. So repeated hemorrhage, no accessible location, and very close to the damage. So these 3 categories, we want to do gamma radiation surgery very actively. And so our using those is very different from ABM. The ABM usually 22 gray, 24 gray, higher doses. So our target is endothelial cell damages. But cavernous angioma, historically, about several papers that demonstrate that the 22 gray, 20 gray using 50% cavernous angioma has a risk of the hemorrhage. So nowadays, we need to reduce the dose and just about 14 gray as a marginal dose. So relative lower dose is very effective to stop the rebleeding. So when we have the patient is a good indication of reduced surgery carcinoma in the brainstem, we wanted to use 14 gray as a marginal dose and covering the including hemogenic limbs. And so we'd like to observe. That's it.
Very good, thanks. One more question, comment before I give the podium as well to the chance to interact with you for this nice presentation. I'm very impressed as a chair of World Federation Neuroanatomy, you focus on microanatomy and especially your presentation on CIS and cranial nerve imaging. This is where complication occurs even by the hand of the radiation oncologist or some of neurosurgeons that are using gamma knife, but not as you are doing with the meticulous anatomical information you got, whether it's a CP angle or supracellular. I have one question on the supracellular tumors at large, taking meningioma, supracellular meningioma, going into the optic foramina, taking pituitary with the residual cavernous around the optic nerve, and craniocalcified craniopharyngioma. What is your take? You give a fractionated on these, or you give a radiosurgery single shot, or how you design your decision, and especially adjacent to the optic nerve?
That's a very good question. So optic nerve is a very weak structure from high dose radiation. So 10 gray is a limit dose to the optic apparatus itself. So of course, we wanted to challenge to use SRS, single shot radiosurgery, because if the tumor is benign tumors, SRS is very, very effective. So if the tumor is in the touch and compressing optic nerve, SRS is a very dangerous tool. That time we like to do SRT fractionated. But so when the tumor is meningioma, meningeal capsule is about 0.8 millimeter. So this is just touched to the optic apparatus, this is meningioma. We can do SRS gamma radiosurgery. 0.8 millimeter distance, we can do micro radiosurgery. But if this is a pituitary adenoma, 0.4 millimeter, very thinner capsule. That time, so 50% of the patient we can do SRS, but another patient we cannot do SRS. So depend on the tumor's pathology. So honestly, so touch to the brain, touch to the optic nerve cases, majority of the patients we can do gamma radiosurgery using microanatomy. This is my honest things.
Craniopharyngioma? Give some comment on craniopharyngioma.
Craniopharyngioma. Craniopharyngioma is, and this is solid tumors. We can do SOS radiosurgery, but cystic type, sometimes and easy to recurrence. So probably fractionated radiotherapy is a better. So, but small cystic, we have a challenge to the SRS, but large cystic, and probably fractionated is a better, in my opinion.
Generally, in our country, we get bilateral acoustic. One is very large, other is very small. So generally, our policy, we operate large one. So can I ask your experience about the gamma knife for bilateral?
Bilateral, this is NF2.
Yeah, yeah.
Yes, so NF2 patients, so for example, the patient right side hearing, left side not hearing.
Yeah.
I want to treat right side. So the other doctor neurosurgeon said, if the tumor is growing, that the patient loss of the hearing, this is a timing of radiosurgery. So this is not for me. So my concept is very aggressively because NF2 is a progressive disease.
Yes.
All of the patients experience of hearing loss in the future. So gamma radiosurgery is not so or disaster treatment. Normal nerve itself is not so weak from the radiation itself. So we use 12 grade to the acoustic tumors. 12 grade itself is not so strong. So when the patient has a hearing side tumor, so this is my first attack of the tumor cell.
Thank you.
I'm very aggressive neurosurgeon.
Yeah, okay. One more question about the stage radiotherapy or radiosurgery that you mentioned. It's a very interesting case because many of us, when we see this large AVM, we got abandoned it and we don't do much on it. And you gave a radiosurgery on the first year and third year, and you consider it of 10th year. Do you apply this stage radiosurgery in tumor cases as well, or only for vascular malformation?
And very good question. So when the tumor located cavernous sinus and paracavernous sinus, we can do stage radiosurgery because cavernous sinus wall is one of the border we can visualize. So if it is a very huge tumor, cavernous and paracavernous, so like a meningioma, and if we have to treat only radiosurgery, so first of all, we'd like to treat only cavernous sinus parts. And 6 months later, I'd like to treat adjacent parasagittal sinus and the middle fossa. So we can do separate stage radiosurgery for the surrounding cavernous tumors. So the other convexity meningioma, acoustic tumors, I cannot do a stage radiosurgery.
One more questions because I have in my center the Cyper knife, and of course that was not my wish, but as I said, who got the money, he got the equipment, they got the money, radiation oncology, they want to have the control, and I was willing to collaborate. What is your take nowadays comparison of Gamma knife versus Cyper knife? Of course, they claim they can treat a wider aspect of cancer of the body because they can take pancreas, lung,
of course,
other things. Yeah, but regarding if you take AVMs, we know the precision of Gamma knife is unmatched. Is still the same, unmatched, or they are coming nearby? What is your take?
Yes, and when we have to treat a patient with atypical meningioma, it's okay, atypical meningioma. So this is wider residual, even if the very good surgery section, wider residual. The time SRS, Gamma knife, is, we cannot cover all. But Cyber knife, they can cover all. And so fractionated radiation therapy, each time it's a little bit smaller dose. So this is prevent surrounding tissue inflammation cell. So atypical meningioma or malignant meningioma or glial tumors, Cyber knife SRT is better than the SRS. But AVM, so my friend has experienced huge AVM fractionated method using Cyber knife, but the result is not so good. So AVM is not neoplasms. So this is a malformation. In my opinion, so AVM using Gamma knife SRS is better, in my opinion.
Now, when you show this vestibular schwannoma and you put the isocenter, the multiple isocenter next to each other, some of them, they overlap, and you mentioned it. This is the hot spots. How you can eradicate the negative effect of hot spots on the facial nerve and on the structure? I know you put them on the tumor as much as you can, but I'm interested to see how these hot spots won't affect that nerve or the structure.
If the patient is with serviceable hearing, so hearing is still good, So we have to spare cochlea itself. So some papers said that the cochlea dose should be less than 4.2 gray. So cochlea, and we can visualize very easier on CT scan. So we'd like to spare intentionally cochlea dose itself. Of course, and we can see the facial notch in the bony structure of CT scan. And we'd like to do 0.2 millimeter space between the bone and the tumor cell. So this is your answer, so that
No, it's not my. You see, you put a lot of isocenters along the nerve, the cisternal part, and on the tumor, and the cisternal part of the tumor. And these hotspots, they overlap. Does this cause a negative effect on the function of the nerves?
No.
It doesn't, yeah? Okay. One more question. I'd like to refer your paper. I read some of your paper, was fantastic, about the NF2. To answer Dr. Virendra, this is a nice paper to go and read it again. And you specify the age of 50, above and below. What make you use that cut line, 50 years old, above or younger?
Yes. And
or large tumor.
So in Japan, the define of the elderly patients is 75 years old. And the gamma knife surgery historical point of view, the paper only 25 years history. So it means 75 minus 25 is 50. So if the patient over 50 years old, no risk of the neoplasm and the malignant transformation, so over 50 years old. But less than 49 years old, of course, we have to explain the patient our treatment option, not only radiosurgery, surgery resection, and wait and scan. And after that, we discuss which one is the best for the patients. So our cutoff line age is 50 years old in Japan. Right. I don't know in the India, the other countries. Yes.
We are joined by our second speaker.
And thank you very much, Dr. Hayashi, for being patient with me. And
thank you very much. So may I kindly inform our viewers that this webinar has been broadcasting in different parts of the world, and Professor Shubin has arranged a WeChat broadcast for this webinar in China. And currently we have nearly 700 viewers who are watching this live, and we are extremely grateful to everybody. We can go to the second chair, Professor Virendra Dev Sinha, to say a short introduction and invite Professor Aguilera for his talk.
So, good evening to all esteemed speakers and attendees on this webinar. And first, I want to thank Professor Yaku Kato, who is president of ACNS, for inviting us to chair this session, and Dr. Raja, who always keen to manage lot of webinar and is very nice for sharing the knowledge of our scientific material. And our second speaker is Professor Sergio Rodriguez from the Chile, and he'll be talking about the moderate traumatic brain injuries, clinical approach to an inappropriate term. We all understand that injuries are increasing and is a global health problem, and it is increasing because of motorization, industrialization, and change of the social values and changing of the value system as well. As far as the severity of the injuries are concerned, is same, I think, almost every part of the world. Maximum they are mild 60%, then moderate 20%, mild to moderate, and severe 15 to 20%. Moderate head injuries not been described previously in the literature, although they cause a lot of mortality and substantial morbidity as well. The main cause of these injuries is because moderate injury can mimic symptoms like mild injuries, and symptoms do not go away or may even get worse with time, and most of the patients, they stay with the residual symptoms. So time has come when moderate head injury should be directed or should be well known in the literature, and we should discuss more and more, because severe head injuries, we know that there is almost irreversible changes, and all forms of management has demonstrated little success. So today we have a very important session of TBI, moderate head injury session, for which Professor Sergio will be talking about this. Can I invite Professor Sergio and share your screen, please?
Okay. First of all, thanks for the invitation to give this lecture. And I'm going to talk about in the next 30 minutes about to moderate traumatic brain injury and a clinical approach to an inappropriate term. The first we have to say is that there is no clinical guidelines available for management of moderate TBA, a difference of for severe includes to mild injury that they have really a guideline. And if you consider moderate TBI patients from Glasgow score from 13 to 9, you will see that the subgroup of patients is about 20 to 15 to 20% of the all TBI cases. And the mortality published in the literature fluctuate between 6 and 15%. And I think that is a very little high number. These are young people with a traumatic brain injury who at the admission has a moderate primary injury, and finally they died during their evolution. And if you look the morbidity, we have usually use a Glasgow outcome score extended. And I want you pay attention to moderate disability, because when we analyze our results or the results of our patient, you usually divide the outcome of the patient in two groups, poor outcome and good outcome. But if you look again to moderate disability, you can see that patients who result in GOS extended, number 5, are patients who are unable to return to work or return to academic activities. If you consider that, you have to see that about 30% of patients with moderate TBI has moderate disability at 12 months, and this is a very big number. And a large proportion of this disability is because our cognitive sequelae that are very disabling for the patient are associated with diffuse axonal damage, not necessarily proportional to TBI severity, and some of these deficits are usually evidenced by attention deficit, memory and learning problems, language disturbance, and mood and personality disorders. Summarizing, if you analyze the moderate TBI outcome, you can see that it depends of at least 3 aspects. The first, the primary injury, that in moderate TBI is not so devastating. The other aspect is the secondary brain damage, that it depends of us, of the all equipped medical equipment who make the treatment of the patient from the pre-hospital period until the ICU. And finally, the outcome in moderate TBI depends on neurorehabilitation. But in too many countries, especially in low and middle income countries, it is just one someday we will have neurorehabilitation. So then, who are the patients at risk of worse evolution and poor outcome? I think that this is the right question. Try to recognize patients with a higher risk of mortality and poor outcome, despite an admission Glasgow between 13 and 9. We will talk about a couple of prognostic factors that are involved in this evolution and outcome. For example, what can we talk about age? All we know that over 60 years old is a risk factor for bad outcome. And these this subpopulation have aggravating factor as the use of anticoagulation or antiplatelet drugs. And the more common CT findings are subdural hemorrhage, traumatic ACH, and brain contusions. If we talk about mechanisms, we have to differentiate at least two different mechanisms. For example, direct impact that are associated to the breast fracture, epidural and subdural hematoma. And the other one that is most important is the mechanism that include acceleration, deceleration phenomena, because this causes diffuse axonal injury, brain swelling, and brain contusion. And it is so much deleterious for the brain, obviously. When we talk about Glasgow Coma scale at admission, we have to recognize that moderate TBI includes a wide spectrum of patients. Patients who talk and obey, for example, Glasgow 13 with a motor score of 6, and patients who only flex to withdraw from pain, for example, Glasgow 9 with a motor score of 4. 75% of moderate TBI deaths were patients with Glasgow 10 or 9 at admission, and especially with Glasgow motor score of 4. You have to remember that motor score has almost the same predictive values as full GCS. For me, and my opinion, a motor score 4 and 5 in moderate TBI should be considered as a red flag. For example, in the chart, you can see that these two patients have the same Glasgow, but they have different motor score. I think that these two patients are not similar patients. And what is information that a CT scan can give us? All we know that is so very important in the evaluation and evolution of patients with TBI. But remember that focal mass injury, midline chief, basal cistern state, and traumatic subarachnoid hemorrhage are related, with the risk of intracranial hypertension and are associated to patient outcome. If we talk about midline chief, remember that when you have a midline chief greater than 5 millimeters, it is associated with poor outcome. But the relationship between degree of midline chief and outcome at 6 months is essentially linear, and you have to take into account. If you look this basal cistern, you can see in the pictures that in the superior image, you can see a normal basal cistern. Below, you can see a basal cistern, compressed basal cistern, and finally, the effacement of the perimesencephalic cistern. And I believe that we have to make this differentiation when you are interpreting a CT scan in a moderate TBI, because it's very important. As you can see, is associated with a different incidence of mortality. If you look the Marshall classification, I just want to show you this figure taken from the Maria Poca from Barcelona, Spain. And it's very interesting because it's so academic figure. And I just want you to pay attention only in diffuse injury. If you look diffuse injury type 2, you can see that the incidence of intracranial hypertension is about 30%. And if you look diffuse injury 3 is 60%. And 100% of the patient with diffuse injury type 4 has intracranial hypertension. And this simple interpretation of the CT is very important to predict the incidence or the risk of intracranial hypertension that a patient with a moderate TBI at admission he has. About type of intracranial injury, I just want to say a couple of words about brain contusion because our injury is associated with a worse outcomes, heterogeneous in its presentation and evolution. 50% of brain contusion progress to brain contusion progress in the first days, and they have complex pathophysiology. Remember that the pathophysiology of brain contusion is about excitotoxicity by glutamate, powerful neuroinflammatory response, especially studied with microdialysis, induced brain edema, an increase in intracranial pressure. And as a consequence, it will contributing to cerebral ischemia and neuronal death. I like so much, and I recommend to read this paper from Kurland, because he talk about pathophysiology of brain contusion progression, and he can recognize 3 different areas in a brain contusion: a central core of the contusion in which we can find tissue disruption, capillary fracture, and initial bleeding. Another part, the penumbra, activation of molecular cascade that will produce late hemorrhage. And finally, a parapenumbra area in which we can find activation of cellular mechanisms that trigger neuronal apoptosis. An important biological mediator in all of this process is the sulfonirulia receptor, as known as SUR1. SUR1 is overexpressed in penumbral areas of brain contusion and are associated to endothelial cells and astrocyte foot edema. All of this is going to provoke blood-brain barrier degradation, endothelial disruption, and capillary fragmentation with hemorrhagic progression of contusion and more brain edema, as you can see in the figure. Another mediator in this process is the metalloproteinases. It is a family of endoproteases that are associated to microglia activity and TNF-alpha effects. They have the ability to degrade extracellular matrix and tight junctions proteins such as collagen 4, laminina, fibronectin, contributing to blood-brain barrier disruption. But go to the emergency room. We are evaluating a patient with moderate TVA, and these are the clinical scenarios that you can find. For example, the first is a young woman in Glasgow of 13 with a motor score of 6 who suffered an assault, and you can see that she has an epidural hematoma. The second patient is a man, 45 years old, in Glasgow of 10 with a motor score of 5, but he was hit by a car. And if you look the CT, you can see that he has brain swelling and probably a basal cister compressed or effacement of that. The next patient is a young woman too with a Glasgow of 12. He participated in a car crash, and you can see that she has a axonal diffuse and maybe a subarachnoid hemorrhage. And the last patient is an older man of 61 years old in Glasgow of 13. He fell from height, and he has bifrontal contusions. Obviously, all these patients are moderate TVI, but we don't have an algorithm to take decision or for a clinical approach with each one of these patients. But what would I do? Maybe you are not agree with me, but this is my opinion. The first case obviously needs surgical evacuation, and after that, only clinical monitoring post-surgery. The second patient for me is the more severe cases. I believe that he needs ICU admission and ICP plus oxygen, brain oxygen monitoring. For me, this patient must be included in a protocol of severe TBI. The next patient perhaps just need clinical and non-invasive monitoring, for example, for pupillometers or maybe optic nerve echography. And the final patient is a very special patient because despite he is in a very good Glasgow 13 with a motor score of 6, he has a phenomenon of acceleration, deceleration, and he presents on the CT bifrontovasal contusions. This patient for me must to be in the ICU, and he needs a strict non-invasive monitoring. There is no algorithm for this patient. All of them are different, and we try to improve our clinical approach to avoid neuroworsening in the first hours. About treatment of patients, I just want to say couple of things about general consideration. The first of all is we need to avoid hypotension and hypoxia because worsen outcome. But a widely accepted recommendation from ATLS is that systolic blood pressure greater than 90 is based on a small series. But this article shows us that there would be a linear relationship between systolic blood pressure and risk of mortality below 120 millimeters of mercury. So I believe that the recommendation should be keep systolic blood pressure from the hospital area to the hospital area attention about or peri 120% whenever is possible. About surgery, especially of brain contusion, there are few clinical recommendations. Just the recommendation from Bullock in 2006, and he recommended the evacuation of any focal intraparenchymal greater than 15 ml. But I would like share with you this paper that I think this is very interesting, is the Stitch, who compared, in which they compare early surgery versus conservative treatment of brain contusion. And what they found, there is a strong case for operating patients with traumatic ACH who have a Glasgow of between 9 and 12 because they have the best response to early surgery. But once the Glasgow has descended below 9, surgical intervention appears to be less effective. What does it mean? The neurosurgeon need to have a most aggressive approach with a patient with moderate TVA and brain contusions. In the medical treatment of moderate TBI, I believe the main goal is prevention of secondary damage, prevention of secondary brain damage. And for that, we need to glycemic control, we need natremia control, avoid hypotension, a strict temperature control, and try to avoid fever episode. And we have to ensure adequate brain oxygenation. In this way, I would like to show you this paper in which they evaluate 119 patients with moderate TBA. 84% of them were admitted in ICU and 50% of them were 3 or more days. Only 15% of them required neurosurgery, and 20% of them needed ICP monitoring. But what the interesting of this article? Basic physiological variables were evaluated, and what they found that patients who were 3 or more days in ICU, they had more hyperglycemia, more anemia, more fever episode with temperature over 38 Celsius degrees, and more hypoxia. And the Glasgow outcome score extend at 12 months goes extended 6 or less, it is to say with disability, was present in 50% in the group of 3 or more days in ICU, and only in 26% in the group from 0 to 2 days in ICU. What does it mean? This paper, for me, reinforced the idea that we have to be very careful with the prevention of secondary brain damage, trying to making an acute control of basic physiological variables during the first days of the traumatic brain injury, especially in moderate TBA cases. If you talk about a little word about ICP monitoring, it's so simple. There is no recommendation for ICP monitoring in moderate TBI patients, but here you have 5 papers with about 1,000 patients, in which 11% of them used ICP monitoring, but about 50% of them have presented ICP over 20 millimeters of of mercury. And what is the importance of that? You can look at these two patients. If you look at them, you can see that both patients have the same mean ICP below 20, 16 millimeters of mercury. But you can see that patient below present two peaks of intracranial hypertension. And in this paper, they measure the area under the curve, and they interpret it as the dose of intracranial hypertension. And why it is so important? Because they found that the dose of intracranial hypertension that is expressed in millimeters of mercury per hour is associated with outcome. It is to say, when you have more dose, worse is the outcome of your patients. Why measure ICP in moderate TBI? The Rescue ICP trial of the comprehensive craniectomy in severe TBI, you can see that the patients who were randomized in this trial, 100 of them have presented an initial Glasgow score of between 9 and 15. It is to say, almost 100 patients who finally needed the comprehensive craniectomy were mild or moderate TBI at admission, and we have to take into account these aspects. And talking about ICP, I have to say that is 22 really the magic number? Remember that it has varied 3 times in the last 2 decades. And I believe that therapeutic threshold depends on the target that we propose. For example, a different threshold is going to be necessary is one to decrease mortality. Maybe another threshold of ICP we need to avoid poor outcome. But I think that we look for a different threshold if we want to improve favorable functional outcome. It is to say, raise the bar and try to avoid Glasgow outcome score extended 6 or less. I think that this is our goal in the future. To this respect, we can find a couple of words that try to say something in this way. Harry, for example, last year, he demonstrated ICP of 19 millimeters of mercury is the ICP threshold most strongly associated with the outcome. Prosinger suggests that the threshold for ICP treatment should be 13 or 14. And the first of all the articles that I think is very interesting to read is from Miller, who demonstrate that in patients with diffuse brain injury, any increase in ICP above 10 millimeters of mercury was associated with worse neurological status and worse outcome. What we have to expect from the future? Obviously, the first that we have to expect is we need to improve our understanding of the different biological injury mechanisms in TBI. We don't know about vasospasm in TBI, more about diffuse axonal injury, neuroinflammation, metabolic changes. This is the first that we have to expect. The second one is the development of more biomarkers. Biomarkers are going to be a specific neuromonitoring for each one of the injury mechanism. And in parallel with that, we will be able to make or to do a real precision medicine approach. What is to say, we are going to develop new treatment for a specific injury mechanism mediator. For example, we can inhibit the SUR1 overexpression, or we can modulate the activity of metalloproteinases or maybe aquaporina channels. This is going to be the real precision medicine approach, but it's going to be in the future. But what do we have now? The only thing that we can do is try to respond to the question, the key question: who are the patients at risk of worse evolution and poor outcome? We published in Critical Care Medicine last December an article in which we tried to answer this question, and we developed a chart that you can see in which we combine two prognostic factors, Marshall CT classification and Glasgow Coma score. And what you can see, that we propose different clinical approach for different scenarios. For example, a patient with Glasgow of 12, we can have different clinical approach depending on the Marshall CT classification. This is that we believe is going to help us to take better decisions with patients. And a couple of months ago in the Chilean Neurosurgery journal, I published this review in which I tried to propose a new clinical approach for this inappropriate term named Moderate Tvi. And I just want to show that this in patients with Glasgow 9 and 10, with diffuse injury Marshall 3 and 4, I believe that this subgroup of moderate TBI patients should be included in a severe TBI protocol monitoring and treatment, because I think that this subgroup of patients are the new severe TBI. Finally, my conclusions are that moderate TBI requires a new clinical approach, redefined, a new classification. I believe that patients with Glasgow between 9 and 13 on admission are rescuable. However, up to 50% of them died during their evolution, and this is a big problem because they are young people. And I think that Glasgow 9 or 10 plus Marshall classification 3 and 4 must be identified as patients with a higher risk of worse evolution, but they give us an opportunity to avoid secondary brain injury and increase good outcome. Remember that the director of the Maryville Resort said that Schumacher was a little shaken but conscious after crashing, but now he's a patient with a severe disability. Thank you so much.
Thank you very much. Professor Sinha, you may unmute your mic, please.
Thank you, Professor Silgo, for excellent presentation of your paper, and you correlated the pathophysiology of TBI with the clinical presentation. And I think before we treat the TBI patient, we must know the pathophysiology of TBI, which is very, very important. And just I want to know your experience of non-invasive monitoring, because in few of your earlier slides, you mentioned that this non-invasive monitoring of ICP. So may I know your experience about that?
Okay, I believe that non-invasive monitoring are very important because a lot of reasons. The first, for example, pupillometers. I believe that pupillometers is a very useful tool. It's a little expensive, for example, for a low and middle income country, but it allows us to avoid the number of CT what we need to make with the patients. The optic nerve sheath ecography is very useful too. Is in every ICU, in every emergency department are ecography. And I believe that's easy to train a medical doctor to do it. Pupillometer, for example, can do it, can be done by a nurse. These two tools I think that are very useful in evaluating patients, for example, with a cerebral media artery infarction, a stroke, ACH by aneurysm. So I believe that is very useful in TBI, especially in moderate cases.
Okay. And second thing I want to know, because as I also told that moderate head injuries were mostly avoided before in the literature. and very few literature is available regarding that. So should we do any changes in the guidelines to give more stress about the for the moderate head injury? Should we do some changes in guidelines, or what we should do new for making the new guidelines for giving more stress for moderate head injuries?
Well, okay. I believe the guidelines did not mention to moderate TBI patients. The last brain trauma foundation guideline are going to be the last guideline, because if they were very good statistical analysis and recommendation based on medicine-based evidence, are very few practical.
Yes.
I participate in the CIVIC protocol in the conference of consensus, and we published 2 articles to present an algorithms to the management of severe TBI, but I have not written until now a guideline for the management of moderate TBI, and I believe that it's going to be very hard to have this kind of guideline because of too many different patients. This is the problem. We in a guideline we mix with a diffuse axonal injury, brain contusion, axonal diffuse, and it's so difficult to make a receipt, a medical receipt to treat all of them. This is a big problem.
Yes. We know that CT scan is very important for TBI, which give speed, accessibility, and high sensitivity. What is your opinion regarding the MRI for TBI investigation, for early detection, and for prognostic for these type of injuries?
Okay, I believe that in emergency room, to initial evaluation of a patient with a TBI, maybe MRI is not necessary. All our decisions are based on prognostic factor, age, CT scan, Glasgow motor score, another factor, but MRI maybe will not change our clinical approach. To evaluate the prognosis of the patient maybe is very useful, especially in patients with low Glasgow outcome score at admission, in which we believe that the patient has, for example, axonal diffuse damage type 3. I believe in another cases, maybe MRI is very useful too, but it's not easy to go to the MRI room with a very severe patients.
Because we recently conducted a very big study, and it's published also, MRI for the prognosis of TBI. So especially HWI image, because that give more information regarding the hemorrhage. So we did all the sequences, and we found that HWI is very sensitive sequence of the MRI, give a very good prognostic prognosis of the TBI patients. And nowadays, what we are doing, we are not getting all other sequences, only HWI sequence of TBI patient, and they give all the information regarding the prognosis, severity of the TBI. So this is our observation. Just I want to share with you. Yeah. So very good. So in chat box, I'm not finding any question. So anything, anyone wants to ask?
Dr. Liu Bun Seng, any comments from your side?
Thanks, Raja. Thank you, Professor, for a very nice presentation. I have 3 questions for you, Professor. What is your opinion regarding the use of tranexamic acid in any intracranial hemorrhage in both moderate and severe injury? Do you think it's really useful? My second question, Professor, skull-based fracture which associated with a more severe injury, which are never in any guideline when we talk about head injury. What is your opinion? My last question, Professor, good practice center, we say that those patients who deteriorate from mild to moderate should be treated as severe head injury in the close monitoring? What's your opinion regarding these three questions? Thank you, Professor.
Okay, I have a problem with your audio, so I did not
He's
listen
asking about
very
first
good.
question was
Yeah.
about tranexamic acid, the drug tranexamic acid for traumatic brain injuries.
Okay, tranexamic acid, the last article published only recommended in moderate TBI with less than 3 hours of evolution. It's the only recommendation that we can do about that. And after the 3 hours, apparently is not improve the outcome of the patients.
So it was excellent webinar by both our speakers, and I think we must continue these webinars. And thank you very much.
Thank you very much, Professor Sinha. It was a great pleasure to have you on board for the ACNS educational activities. I will wind this up officially on behalf of the Education Committee of the ACNS and the President of Suyoko Kaito. I would like to sincerely thank both the speakers of today, Professor Motohiro Hayashi and Professor Sergio Aguilera, as well as the chairs, Professor Imad Kannan and Professor Virendra Sinha, for the time and support for the ACNS webinars. We are extremely grateful to Professor Shubin, who has arranged a WeChat broadcast for this webinar in his country. And today we have nearly 700 viewers who are watching us live across the world. A special thanks to my co-host Liu Bun Seng for joining in today as my co-host. So until we all meet on the 11th of September, it is bye-bye from everybody. Thank you everybody who joined.